Good evening. Thank you for coming. I would like to thank you for coming. And I know that time is an asset does not return to you. So your time here will not be in vain, as I will help you hope to answer some questions and guide you through the DSM, its purposes, and some of the challenges that now arise. I assure you that the PT has asked me to be here to assist in making sense of the many diagnoses that have now come upon your children through the Diagnostic and Statistical Manual of Mental Disorders, otherwise known as the DSM. Specifically now, we're at the Dsm5. The original DSM was done in 1994, and there have been 5 since then with incredible amounts of changes, as well as each one of them has caused an incredible amount of controversy. Anytime a manual is tagged with the name Bible of ... I get a little queasy. Let's be honest. There is only one true Bible, and the reliability and validity of that Bible, the original Bible, cannot be duplicated. So, with that being said, there are many clinicians who view diagnosing through the DSM as the guidebook by all mental health, including all the psychiatric diagnosis within it as the pinpoint accuracy for all patients. Others in mental health field feel the DSM is primarily used for diagnosing for insurance reimbursement and should be used as more of a guideline and not a Bible of diagnosing, as we are still in our infancy of understanding mental disorders and the mind. The truth is, the DSM is limited because we, in fact, are limited in our knowledge in how mental disorders work. I do say it is critical that assisting in mental health in the way of disorders that is shared language for clinicians, doctors, and mental health professionals have matching ways of speaking in agreement, especially when it pertains to the more disabling disorders like schizophrenia, autism, bipolar depression, OCD, etc. The Dsm5, when paired with clinical judgment, can be useful. Without clinical judgment, it can be extremely harmful. The Dsm5 states in its introduction that it is not to be used as a cookbook, so it itself would not be want to be paired with the Bible of mental health or anything of that nature. The Diagnostic and Statistical Manual of Mental Disorders, DSM, is published by the American Psychiatric Association, otherwise known as the APA, and is used to diagnose mental and behavioral conditions, including personality disorders. It contains detailed descriptions, symptoms, and other criteria that are important for such diagnosis. For those of you who are familiar with the previous DSMs, you are aware of how vastly different the DSM-5 is in comparison. One of the biggest changes, first and foremost, is the introduction of the classification of autism spectrum disorders. In order to make a diagnosis of autism spectrum disorder, at least 5 out of 7 criteria must be met. The second most significant big change, which is the one causing mass uproar and confusion, is the elimination of separate categories under the new ASD heading. What this means is that the new manual no longer recognizes specific diagnoses such as autistic disorder, Asperger's syndromes, PDD-NOS with DSM-5. Most of these disorders now fall under the classification of ASD, Autism Spectrum Disorder, or Social Pragmatic Communication Disorder. If you have a child that has been previously identified as someone with PDD, NOS, or Asperger's, and then you are told the diagnostic no longer exists, this can be confusing and upsetting for parents, to say the least. I am not here to convince you to follow the DSM-5 blindly, reassuring you that each diagnosis is so expertly selected and each criterion so flawlessly created that it can pinpoint all issues without question and knows your child better than you do. What I do believe in is empowerment. I cannot successfully empower you to make well-informed decisions regarding your concerns with the DSM-5 without divulging the truth as I understand it regarding the DSM-5. The DSM itself has been, since its beginning, great controversy. Much like attempting to sell a car to a used car lot, in case any of you have believed in CarMax, and looking at the Kelley Blue Book as a reference or a Bible, which to do so, only to find out it was not for the ease of accuracy, but yet to put the favor in the hands of the used dealer that it was created for. Many debates by professionals argue quite convincingly the same with the DSM-5. A recent interview backing this debate was by Jeffrey Lacasse, who spoke of the private guild, who makes its profit by selling the DSM-5, and this private guild itself gets to determine without any accountability who is mentally ill and who is not in our society. I find as a practitioner that to be far too much unchecked power for a private guild to have. This definitely raises questions as to the purpose and diagnosis that came from the DSM-5 and the link between psychiatrists who benefit from prescribing the drugs from the many diagnoses of the DSM-5. And these have not gone unnoticed, along with reliability issues that would be in direct contradiction with the purpose of at least social work in our field, along with liability issues that would be in direct contradiction with that as well. We're here to actually help people and advocating for them, for those who cannot do so for themselves. In his book, Saving Normal, psychiatrist Alan Francis states, cautions that the newest edition of the Bible of Psychiatry, the diagnostic DSM-5, is turning our current diagnostic inflation into hyperinflation by converting millions of normal people into mental patients. Later, he backs what we spoke of earlier by stating, stigmatizing a healthy person as mentally ill leads to unnecessary, harmful medications, the narrowing of horizons, the misallocation of medical resources, and the draining of the budget of families and the nation. This moves us from well-being into the hands of Big Pharma. I liken it to the ongoing controversy of desirable school lunches. I'm sure if we laid menus in the hands of the parents, we would come up with the healthiest meals that our kids would never eat. They would also most likely be the greatest bland options that our children would still refuse to eat at the same time. Yet there are students, as a matter of fact, that are too many students, that if they were not provided school lunches, they would have no food at all. If a man walks in a psychiatrist's office having been labeled with major depressive disorder of a severe nature, and he might be described antidepressant medications, yet finding out he lost his wife and child in a car accident 4 months ago, we might want to gauge what is considered a normal time frame of grief and response to the emotional pain he's experiencing before prescribing a pill that would make him feel normal. In a more bizarre finding, the DSM-5 has also changed the definition of what is labeled a mental disorder. That means that they are unsure of what is considered normal and what is considered disorder itself. I would believe that to be shaky ground to put all my faith in when diagnosing anyone within my family. I know I am bold and straightforward. I haven't come to offend, but to empower you. I've also not come here to lie to you or persuade you of anything. On the contrary, I've come to provide support and would like to open the floor for any questions you may have at this time. Ma'am, I thank you for being a mother who loves her daughter. You care enough to not blindly take suggestions, but to seek what is the best option available for your child. And that is such a joy to hear. I'm saddened whenever I hear the word suicide, due to the incredibly robbing nature of a life. I remind people I've worked with in the past in such scenarios that suicide is never the option, especially when you have no clue who you are killing. You have no way of knowing how the situation is going to end or how great the ending of that book of life is going to be. I remind people to look beyond the sentence, paragraph, and chapter and know that the book can continue. That being said, in the wake of tragedy, the severity of the tragedy, the closeness of those involved, the quake effects of adolescents who assume they are invincible, then are thrusted into the harsh reality that tomorrow is not promised all at once, can be devastating without a 3 to 6 month expiration date of sadness. What stands out is that she is still not willing to talk about it. It is normal for her to get upset over the suicide of her friend, and it is healthy that she talks about it. When looking at depression versus grief, regarding the DSM-5 is where I am skeptical of purpose. Under the DSM-5, a psychiatrist would be allowed to diagnose your child with a diagnosis of major depression, whereas traditionally she might be experiencing a variation of normal grief. She might get a mental disorder label depending on the clinician's adherence to the DSM-5 if the current symptoms were for 2 weeks after the death. She feels sad, doesn't want to go to school, loses her appetite, has trouble sleeping and concentrating. The fear that I have in such situations is that we begin to provide false positives of diagnosis, such as being diagnosed with major depressive disorder, as opposed to grief. I am not in any way saying that you should not have your daughter seen by a psychiatrist if you feel she has been experiencing grief for an extended period of time and experiencing those symptoms that we previously mentioned. My suggestion is that you take the opinion with a grain of salt, considering what you know about the DSM-5 they are using. Never be afraid to ask questions, many questions, as to how a conclusion has come up with regarding your children or a treatment plan. I believe we are all well aware that meaning and purpose must precede objectivity. Advocate for your child like their lives depend on it, because it does. I'd like to thank the PTA as well as all of you for your time and having me here today. If there are no many questions and any other questions, thank you and have a great night.